high proteinuria,
proteinuria up to
3.5 gram per day.
first how much?
3.5.
3.5 what? What is that in?
What is the problem?
No. 3.5
Milligram.
no. Yes.
I said gram per day.
Yes. 3.5 grams per day for the whole human. Okay. But it is in grams, not in milligrams. Then the second feature is
Lipid up or
hyperlipidemia or hyperlipidemia. Then hypoalbuminemia, edema, and C for, do you remember the
cholesterol up.
cholesterol up. Do you remember
Protein
protein leak?
Yes.
So it was. And do you remember the diseases which were presenting with nephrotic? Okay.
Let's say
3M,
3M.
Paris.
1F. No, Paris was nephritic.
Ah,
1F.
3M, 1F, and
1S.
Okay, so what were the 3M?
Minimal change.
Minimum change.
Membranous.
Membranous.
Membranoproliferative.
Membranoproliferative.
Focal.
Focal and
Systemic.
segmental, and
Systemic.
which includes
Diabetes.
diabetic,
Hypertension.
SLE.
SLE sometimes, and some other rheumatoid arthritis, some other autoimmune diseases, they can be grouped under this. Okay. So we are coming. This was left last time because of time. So there is. This is the manifestation of diabetic microvascular disease mainly, but diabetes is involving at the macrovascular level and also at the microvascular level. At the macrovascular level, it is causing atherosclerosis, it is forming atheroma, it is causing damage and injury to the blood vessels, but it is also damaging at the level of microvessels, at the level of capillaries also. So this phenomena, because the capillary, the vessels which are running in the glomerulus, they are capillaries, parts of capillaries, very fine vessels. Okay, they are very fine vessels. They are very small vessels. So that's why when they are involved, we see that the functional unit of kidney, that is nephron, that is damaged, or that can show effect of glomerulonephritis. So it's mainly a diabetic microvascular disease, and diabetes mellitus is the commonest cause of end-stage kidney disease in the developed world mainly. So those patients who are diagnosed that their whole kidney has damaged, end-stage kidney, which is the major cause in developed countries because of diabetes mellitus.
Doctor, how is this different from focal and segmental? Because it is also the commonest cause of adults.
Yes, but we are talking about end-stage
Ah.
kidney disease. We don't say what is the incidence-wise common. Once the glomerulonephritis happens, and ultimately it causes kidney failure. So the failure in end-stage kidney means kidney failure. So the cause of chronic kidney failure is the most common cause in the developed world, not in the developing yet. In the developed world is diabetes, because diabetes is more common. It is now, there are two types of major diabetes. There are some other types also. Maybe you are familiar with MODY. You know the types of diabetes mellitus? Diabetes?
Type 1,
Yes.
and type 2,
Yes.
gestational,
Yes.
and there are small types related to the genetic defects.
Yes, for example.
The genetic defect B cells.
Okay, did you remember the name of that entity? That typical
No,
diabetes? So we call it as MODY.
Insulin action. Genetic defect in insulin action.
MODY.
MODY. It's not, that this disease is moody, having mood, but the spelling of mood is MOOD, but it is MODY. What is? Maturity onset diabetes mellitus of young ones, of young people. Okay, so this is something which is purely related with genetics, and this is a micro or mini type of diabetes, which is now third major type which has been there. But there could be gestational diabetes, there could be systemic diabetes, secondary, or we can say secondary diabetes mellitus. So inshallah, I hope so, in endocrinology with Dr. Nadeem, we will be discussing about some of the M2. Rather, this is going on M2. We will discuss somewhere in your cases, or
Yes, in this case we have internal medicine.
So type 1 diabetes it's mainly the duration related. The more duration, especially nearly 15 years, they are ultimately getting into diabetic nephropathy. But unfortunately, the type 2 diabetes mellitus, which is more common, they found not a very true relationship between duration. It has happened that somebody was diagnosed diabetes mellitus now and already his kidneys were damaged. Or it happened that a person has diabetes for a very long time, 20 years, 25 years, but still his kidneys are not affected. So they found that a true relationship with duration is not very accurate in cases of type 2 diabetes mellitus, but it is very accurate in type 1. But one thing which they noticed, that those people who have a good control of diabetes mellitus type 2, their risk of developing diabetic nephropathy is definitely less. So those people who are diabetic, but still they have managed to control their diabetes. Did you know a test by which you can know the control of diabetes for the past 3 months?
The hemoglobin A1C.
Yes, it's called hemoglobin A1C, HbA1c. It can give you an idea about the last 3 months control. Okay. So those people who don't have a proper control, or those who are having a proper control, and we also give them typical typical inhibitors which are called ACE inhibitors for their hypertension and other things. They are believed, they are found that their risk of developing diabetic nephropathy is less. Okay. So what is the pathogenesis? You know that a lot of diabetes is related to hyperglycemia, but you will also came to know that it is not only hyperglycemia, rather there are specific products which are called AGEs. Which are called? AGEs. What is AGEs? It is called advanced glycosylation products, end products. What are these advanced glycosylation end products? Actually, excessive glucose binds with proteins and different amino acids of, where our whole body is comprising of proteins and amino acids. So it makes some permanent bonds, the excessive glucose levels, with proteins and with amino acids, and these bonds or these compounds of glucose and proteins, they are called AGs, or advanced glycosylation end products. Once they are formed, they are kind of very strong in relationship or in combination, and they accumulate in different places in the body. Specifically, they deposit in the level of microvessels in the glomerulus. So they causes more and more thickening of the glomerular basement membrane, and they also cause a lot of damage to this membrane, which causing this membrane to become more permeable. If you can remember the last lecture, that the pores get thicker and bigger, that's why allowing a lot of proteins to pass through them. Number 2, hyperglycemia itself is one of the factors which causes the mesangial cells, which are scattered here and there, to become more proliferated. So the second effect by diabetes itself is that it causes mesangial cell proliferation by hyperglycemia. And number 3, which is also one of the features, is that the changes in the cytokine signaling. They believe that in diabetic patients, actually adipocytokines, which are one of the, maybe inshallah you will get about this in your case, and you will learn about that what are the different mechanisms which can cause diabetes mellitus in the pathogenesis, and also about the complications. So this diabetes is actually causing the signaling of cytokines to become disturbed. That's why they causes more and more injury to the glomeruli, causing the pores, or the inflammation is one of the reasons to causes increased permeability, to causes damage to the endothelium. So this is one of the reasons that we can find a lot of membrane changes in this. And it's not mentioned here, but sometimes even the amyloid deposits, amyloid-like proteins are also deposited with it. And that's why once all these are happening, we see that the glomerular basement membrane is thickened. The basement, obviously this is related with this, then the mesangial matrix is increased because of this. Typically, they are forming nodules of thickening of glomerulus. You can find this nodule here, there is a nodule here, there is a nodule here. So this thing is called nodular glomerulosclerosis, multiple nodule formation within the glomeruli. And this is called as Campbell-Steele-Wilson's nodules. This is the typical nodule who diagnosed or who saw these kind of nodules in diabetic patients. So based on his name, they call them as Campbell-Steele-Wilson's nodules. Moreover, they find that there are typical some damage and injury to the endothelium, and to the podocytes. So we find some lesions, some insudative lesions at the level of these endothelium and parietal epithelium. That's why we find that there are either just below the endothelium of the blood vessels or just at the parietal layer of the Bowman's capsule. So we find some lesions sometime here besides this parietal layer, and sometimes the endothelium of the blood vessels. Typically when we go to electron microscopy picture, we can find these insudative lesions at that place. And sometimes we can also have a picture like not focal and segmental, rather segmental and global. Means
All the
some of the glomeruli, part of the glomeruli is involved, and wherever the glomeruli, all are involved. So this is called segmental and global glomerulosclerosis, which is a typical feature of diabetes. The last point. So we discussed already in focal and segmental. For example, there are 6 or 7 or 8 of them. So in focal, what was happening? Few were involved, not all were involved, it was called focal. Then what will be global? All will be involved. So this is called global. And segmental means
Segment.
part of this, part of this. As you can see, not the whole, sometimes only few parts, and rest is okay.
Doctor, what's the meaning in insudative?
Insudative lesions. Once there is injury and there is deposition of these cytokines and some endothelial membranes, so they deposits below the endothelium of the blood vessels, and they also deposits near the parietal layer of the Bowman's capsule. So these deposits, they are also called insudative lesions because they look like as if they are dropping something from the outer layer, or there is something from the inner side. So they
So
are
insudative
dropping. Yes.
But EGS, EGE, I didn't get the phone.
Where is EGI? This one?
Yeah.
Yes, actually, diabetes is hyperglycemia,
Yes.
but this hyperglycemia is not alone. Rather, this excessive glucose is going to bind with proteins and amino acids. And when they make bond with each other, these bonds of glucose with amino acids or proteins, it is called AGEs. It is called advanced glycosylation end products. So after formation, after making bonds, we call them as AGEs. Now these AGEs are kind of undissolvable things, and they deposits here and there in the blood vessels, in the capillaries, in different parts of the body. Here in these cases, they are typically depositing at the level of the endothelium and glomeruli. Hello brothers. See. Then you say, doctor, why you finished 10 minutes later? See, if we want to be straight, we can do a lot. So try to follow yourself. Otherwise you will suffer, not us. Okay? So these are deposited at the level of the basement membrane of the endothelium of the capillaries. You know the filtration membrane?
In the kidney.
In the kidney, starting on one side is, not talking jihad, huh? Then on one side is endothelium,
Yes.
then glomerular basement membrane, then the podocyte. So this is filtration membrane. So these are deposited typically at the level of the basement membrane, causing the basement membrane to get thickened and injured, causing the permeability to increase. Okay. So did you remember what were the causes of nephritic syndrome?
Caries.
With what is the meaning? What is the
Post
abbreviation for that?
streptococcal.
P for
Post
streptococcal.
streptococcal.
A for
Albert.
Albert syndrome. R for
R for لا
Regenerative or repeatable?
لا
That's called rapidly progressive. What is the meaning of rapidly progressive? It is going, or it is causing disease at a very rapid speed. So progressive means something which is going in the forward direction. Rapidly means in a very fast pace.
Yes. SLA.
Okay, rapidly progressive, and then other I is
IgA.
IgA.
IgA or SLA.
Okay, so these are these same things. So this is a kid, I told you that I will tell you this periorbital swelling early morning is actually caused by one of the nephrotic syndrome, which is called post-streptococcal or acute post-streptococcal infection. Nowadays, even they don't call it post-streptococcal, rather they call it as post-infectious. Brother, what's your good name? Your name? Where is that? Where is your business? it's 21 minutes. Huh? So 15 minutes is official allowed, still up to 20. I said occasionally, we can give occasionally, but it is too much, okay? So it's acute post infectious. Why? Because they found not only the streptococcus can cause it, rather other infectious agents, even the viral diseases, they can cause damage to the glomeruli. For example, they found that the pneumococcus, they found that the viral
Hepatitis.
diseases like mumps, measles, chickenpox, hepatitis B and C, all of these, they are also causing damage to the glomeruli. That's why, and they end up into nephritic syndrome. That's why nowadays they call this disease, which was previously called as post-streptococcal, to be replaced with post-infectious, because it's other than streptococcus which can also cause it. What we find? We find all the features of nephritic. We find gross hematuria, we find oliguria. What is meaning of oliguria?
Decrease the urination.
Decrease your
Decrease amount of urine.
Okay, in children, especially following a streptococcal infection of the skin or of throat. Did you know any other disease which typically has this kind of disease?
Rheumatic heart disease.
Yes, rheumatic fever
Yes.
and rheumatic heart diseases. They are also occurring 1 or 2 or sometimes up to 3 weeks after an untreated streptococcal infection of throat or the skin infection. So they can also causing antibodies, you know, the typical
M proteins.
which find against M proteins. So the mechanism is the same. What is your name? Hello? You have a name?
Anwar.
Anwar.
Yes.
And Abdul Majid. Alright, so most common cause of nephritic in children, pathogenesis. Now remember, if we ask in exam or anywhere that most common cause of nephrotic in children is
Minimal change.
minimal change, and most common cause of nephritic in children is
Acute post-infectious.
post-infectious. So remember this difference.
Yes.
What's different?
Yes. The difference is the most common cause of nephritic in children is this.
Yes.
But the most common cause of nephrotic in
Minimal
children
change.
is minimal change. We just last time we discussed. Pathogenesis that they form, that the immune complexes are formed. No please, no talking. There is injury caused by complement activation via classical pathway. You know about this pathway in physiology?
With
Classical
Dr.
complement.
Nadeem.
Oh, with Nadeem?
Yes.
Okay, so you are now fresh with this. So actually they believe that this is the complement activation via classical pathway, which is ultimately damaging the glomeruli because of this infection or the antibodies which are occurring here. Now, the morphology is that typically they found that the glomeruli are very cellular. You can see all these black dots, they show cellularity or the nuclei. So if you compare it with some others, you will find typically, even this is cellular, but it is mainly mesangial. If you compare the nucleus of any other, you will find that this is typically very cellular. And since it is after an infection, so you know that in infections, typically you should have any inflammatory cells. And if it is acute, so what would be the cell?
Neutrophils.
Neutrophils. So typically we find a lot of neutrophils, and sometimes if it is
Monocytes.
going into convert into a kind of acute and chronic, you can also find some monocytes and macrophages. So there is hypercellular glomeruli, diffusely, all of them, and there is increased endothelium and mesangium. So within this, you will find that not only the endothelial cells are proliferative, rather the mesangium is also proliferative. There is granular deposits of IgG and complement on immunofluorescence. So we find that there are granular deposits, there are granules. If you see immunofluorescence,
Yes.
so this is the granule, this is granule, this is granules. So they find, because the mechanism of this disease is complement activation. So you will find a lot of granules of IgG, which is antibodies, and complement proteins. Both are found in the glomerulus on immunofluorescence. And 95% of the cases, this patient, these boys and girls, they are recovered. Sometimes with steroids, sometimes with antibiotic therapy. So your recovery with this disease is very good if a person got treatment. But if a person don't got or a child cannot get medical help, sometimes it can end up into, rarely into renal failure. Then we are discussing another nephritic, which is IgA nephropathy, also called Burgess disease. It's the most common cause of recurrent or gross hematuria. So if somebody is presenting with a recurrent hematuria, blood in the urine, which is coming again and again, which is recurrent, and that is showing a gross hematuria, means even if you can see with your eyes, naked eyes, then most likely you will suspect about IgA nephropathy. There is mild hematuria. So a hematuria will be a very common feature, whether it is the first episode or later episodes, because it is also a nephritic disease which is presenting with hematuria. Again, the proteinuria will be mild. In all nephritic, it should be mild or mild to moderate. Pathogenesis. If you have to talk anything, Dudar, talk with me. Okay? I'm noticing it up to 10 times. Morphology. There is light microscope. You will see it will be variable. From normal to diffuse mesangial proliferation. So on morphology, you will see that the mesangial cells typically they are proliferative. They are proliferated here. And on immunofluorescence, you see that these are actually not IgG, not IgM, rather typically IgA only, which will be highlighted by this disease. So this mesangial proliferation can be seen in diabetes, can be seen in post-streptococcal, can be seen in some membranoproliferative. So how you will differentiate? You have to get help from immunofluorescence. So the immunofluorescence will help us to differentiate this from the other which also have some mesangial proliferation, apart from other helpful distinguished features on light microscope.
The abnormality is going to be on the receptor itself or the immunoglobulin A itself?
Yes, actually it's mainly the deposition which they believe is at the receptor level, at the attachment level where it is happening. So it's not an abnormality of IgA itself. It's an abnormality of excessive deposition of IgA at the level of the nephrons causing damage.
We took this one in hypersensitivity reactions.
Doctor.
Yes.
What's the
How-
relation between this?
Please, what's your name? Huh? Khalid, which Khalid? Khalid Wahid?
Doctor.
What is the relation between this one and hypersensitivity
No talking,
reaction?
please, no talking, set it down.
Because when we took it with Dr. Nadeem, we took this one as an example of hypersensitivity reaction.
I'm absent.
As you like.
No, I'm just asking you because I'm sorry. I have things to do.
It's good, then there are a lot of things you can do, no problem.
I can go.
Okay, it's up to your choice. So, then the rapidly progressive.
Oh, doctor, I have a question.
Yes, yes.
How to differentiate between IgA or IgG in immunofluorescence?
Yes, it is very simple. Actually, when you use immunofluorescence, you use only many types of antibodies. There is antigen-antibody reaction. Once you are going for checking your blood group, Abdul Majid, not wrong. So when you are going to check your blood group, what you do? They will take a blood on the slide.
3.
They will make 3 drops, and then they will put antibodies against positive, A, anti-A, anti-B, and they will also do for positive or negative. Okay. So, just by seeing the antigen-antibody reaction, we can say this is A positive, B positive, or AB positive, like that, isn't it? The same thing we use here. We use different seras which contain IgA or complement or IgG or IgM, and in the same biopsy we use it and we apply it, and we see the attachment with the antigens. So if they are attaching to that, it means it is IgA. If it is not, it means it is something else, and then they use the second antibody, then the third, and like that.
So the problem is going to be on the receptor going to be fine and the immunoglobulin is going to be fine, but the problem is the accumulation of the immunoglobulin A.
Yes.
The rate of the clearance is going to be low. Is that it?
The rate of clearance of antibody or the solute or the urine
Of the antibody.
of the antibody, yes. See, the rate of clearance will definitely be less once they are deposited. But here we are more concerned that because of this deposition, actually what we are getting, that the glomerular basement membrane from where the filtrate or solute has to pass, because of this damage, they are causing more injury and damage. You know, wherever there is antigen and they are binding with antibodies, they are causing antigen-antibody reaction or complement activation. And this will cause damage to the basement membrane. That's why we see a lot of widening of the channels of the filtration membrane, and ultimately a lot of molecules leak out. So in this case, we are more concerned because of kidney, that why they are damaging our kidney at the glomerular level. Okay. So regarding that, whether their clearance is hampered, definitely it is one of the mechanism or one of the thing associated finding is that IgA will not be cleared as normally as the other ones. Okay. And you know about IgA, that IgA is an antibody which is usually seen in secretions, isn't it?
Yes.
In milk, in tears, okay. So you can find it is in GIT also. So it is mainly in a lot of secretions. So they found it has typical role there, and by some defect there, it is also damaging deposition at the level of glomeruli, causing it to damage the glomeruli, and then typically we call it as IgA nephropathy or Burgess disease.
IF for what?
Immunofluorescence. IF, no, this is immunofluorescence. Okay, this is a kind of typical special microscopic technique where we detect certain antibodies and a certain complement proteins. By
For
this.
IgA. We
Not for IgA, for all of
No,
the diseases.
in this case, we
In this
use
case-
it to.
In this case for IgA.
Okay.
Rapidly progressive. So you remember Paris. So the second was Alpert's. We will come afterwards. The third was R, rapidly progressive. Well, some authors, they group this disease separately, then nephritic or nephrotic. But because most of the time this disease presents with excessive hematuria, mild proteinuria, and other features of nephritic, so then other authors, they prefer to put it in nephritic syndrome. So in some books and in some high literature, in postgraduate literature, we find this disease as a separate entity. Okay? So not be confused, but because it is mainly presenting with nephritic picture on lab investigation, that's why they group it here. But it can sometimes be nephrotic also. So rarely, but mostly it is nephritic. Clinically, it has having definition that there is a progressive loss of renal function. You see the word rapidly progressive glomerulonephritis. So there is damage to the glomeruli which is very progressive with severe oliguria. So there is a lot of oliguria, or ultimately a patient cannot pass normal urine with this damage of rapidly progressive. So there is so much damage that the normal urine is not filtered at all, or the filtrate is not formed. Microscopically, what you see there, we find hilal. Crescents for, as you use the word crescents, means halal. And halal, if you see, it looks like the, half moon, as you see. So most of the time when we see under microscope, then we see that the Bowman's capsule or the Bowman space at one side is obliterated by a hyalinized glomerulus. So the glomerulus at this side is typically stuck or bind. Normally, if you see, compare it with previous ones, it will be all
The
around
space
clear.
is
The
obliterated.
space is colored, clear. But in this disease, typically you will find that the Bowman's capsule is mainly obliterated, and it is obliterated by a sclerosed body, by a sclerosis. So this hardening at this one side is giving its appearance, which is called crescenteric. So some people, they also call this disease, instead of rapidly progressive, as crescenteric glomerulonephritis, typically because of this appearance. So there are three types. Type 1 is having antibodies against basement membrane. Type 2 is having immune complexes which are deposited in these places. And type 3 is called pauci-immune. What is the meaning of pauci?
Pus.
Not pus. That is P-U-S, pus. It is pauci, P-A-U-C-I, pauci. The word P-A-U-C-I, pauci means deficient. Something which is not there. So in the third type of rapidly progressive, we don't find proper immune, or rather antibodies or any immune complexes.
Absence of immune.
So absence, you said deficient or absence of immune type cells. Microscopically, we see a lot of microhemorrhages. So these are red reds areas. These are actually typical microhemorrhages which are happening here, which are called petechial hemorrhages. There are crescents. You can see this crescent at this place, and we see at some segments. Not the whole glomerulus.
The
This
last
segment.
one.
Yes,
You're right.
typically it is showing a lot of necrosis. So there will be necrosis which will not be in the whole glomeruli, rather the segment of glomeruli will be showing a lot of necrosis. Then the Albert syndrome, which is actually type of hereditary nephritis. They believe it is because of mutation in genes which are encoding the basement membrane. So nephritis is accompanied, why we call it as Albert syndrome? You know that syndrome is always group of diseases or group of signs
Clinical
and symptoms,
symptoms.
clinical manifestations. In this case, Albert syndrome will have nephritis, damage to the kidney accompanied by deafness and eye disorders. Okay, so because Albert syndrome is again against antibodies or damage typically to the or mutation typically in collagen 4. You know the types of collagens? From 1 to 18, there are so many types, but the most important one are the initial 4 and 5. So this one is against type 4 collagen, which is actually present everywhere in the blood vessels, especially in the microvessels of the eye. That's why there is retinopathy. It could be involving the nephron. It could be involving our deafness, our nerve. The nerve deafness can be caused, and it can also involve the kidney. So this combination will be called as Albert syndrome. So it can involve lens dislocation. Even the lens sometimes can fall back. It can cause posterior cataracts. So the posterior wall of the lens typically it can have this phenomenon, and even the cornea it can be dystrophic in some cases of Albert syndrome because of problem or mutation in type 4 collagen. Morphology in light microscope you will find no change, but on electron microscope you will find that the basement membrane of the glomeruli are typically very thin. So that's why they group these diseases, hereditary nephritis, as thin membrane disease. So the basement membrane, if it is like 2 millimeter thick, it will become less than half. It will become 0.7 or 1 like that, thinning of the glomeruli.
You said Albert syndrome is related to type 4 collagen.
Yes.
What is the difference between this and Ehlers-Danlos syndrome?
Ehlers-Danlos syndrome. Ehlers-Danlos syndrome can also present with Albert syndrome because it's also one of the disease which can damage the kidney in this form. Okay, but Ehlers-Danlos will not have eye deafness, ear deafness, or ear issues. However, type 4 diseases, Ehlers-Danlos is typically involving in type 4, which is involving the skin, fascias, and other things. So we will find a lot of stretchability in those people who have this. So these are the main diseases. The third one was SLE, and because SLE in autoimmune, most likely they will be covering this. All autoimmune diseases, they will also damage the kidney by deposition of the antibodies in the glomeruli also. For example, SLE or rheumatoid arthritis. So ultimately, they will also cause deposition of these antibodies and ultimately damage, and we can find a lot of inflammation and hematuria in the urine because of that. Another topic which was associated with this, or if you see the schedule, was the tumors of the kidney, renal tumors. So the tumors of the kidney could be benign and it could be malignant. The benign tumors are mainly 4, but there are 2 which are very important in benign. Number 1 is the angiomyolipoma. Angio means vessels.
yeah.
Myo means
Muscles.
Lipo means lipids or fats. So actually this tumor is a combination of blood vessels, smooth muscles, fat, and all these things. They become an amalgam, a mixture, a mushakkal, and ultimately we see that mushakkal or that mixture inside the tumor.
Is this teratoma?
No, it's not teratoma. Teratoma is derived from this they believe is a kind of a hamartoma. Okay, a kind of hamartoma, because these are the normal things, but they got increased in it. But because hamartoma should not make a mass, should not be capsulated, but this tumor is found to be ultimately have a capsule. So that's why they say it is having an origin like hamartoma, but hamartoma is not a tumor. So, but this is a proper tumor with a capsule, with a with a boundary, and you can easily appreciate it can form big masses. Another tumor which is very common is oncocytoma. What is the meaning of onco?
Cancer.
Oncology is
Yes.
for tumors also. Actually, we say this word onco for the oncocytes, and oncocytes are the cells which produce excessive hormones, which have excessive granules in their belly, in their lumen. So typically, I will show you the picture. So oncocytes have a lot of actually mitochondria. So because of this mitochondria, when we see them, we will find that the cytoplasm is full of granules. And when we go for electron microscopy, we find that they are all studded with mitochondria. So those normal cells which are in the production of many proteins and many, you can say, they have to produce a lot of power, so their mitochondria get increased, so they will also have this kind of appearance. And this kind of tumor is seen in many areas. You will find this kind of, we also call them in the thyroid, we call them Hurthal cell tumors, Hurthal cell change. It can also be seen sometime in GIT, it can also be seen in other ways, but in this area, in the kidney, we call them as oncocytoma. The other ones are fibroma or hematoma and the papillary adenomas. These can be there, but they are less common, but these are common ones. But among them, oncocytoma is the most common one, or it is important for undergraduate levels. Then the malignant ones, it could be renal cell carcinoma, also called as clear cell carcinoma or adenocarcinoma, and another name for this tumor is hypernephroma. So don't be confused with these names. There is a single tumor which is called renal cell carcinoma, but these are the different names for this tumor. Then there could be urothelial tumors. Sometimes you know that the pelvis and the calyces, they are also in the kidney. You find at the hilar area. So sometimes a tumor can arise from there and then go into the parenchyma of the kidney. So that will have a morphology like transitional cell carcinomas. And the third tumor, which is very common in children, not in adults, that is called Wilms tumor. That is called Wilms tumor. So we start with the first one, oncocytoma. Oncocytoma arise, we have 6 minutes. How we will pass this time? So oncocytoma, it arises from the intercalated cells of the collecting ducts. So you know the collecting ducts in the nephron,
Yes.
the last organ is the collecting ducts. So the collecting ducts have histologically a cells which are called intercalated cells. This tumor typically arises from those cells. They are 10% of all renal tumors. So they have usually find some genetic changes. That's why their intercalated discs or cells become proliferative. And grossly, we can see that they can attain very large and big sizes. And their color is typically brownish, but in English people, you know, those who have good color sense, they call it as mahogany brown.
Type of food.
Type of food or type of brownish color, which is looking like this. So it is called mahogany brown color, which is a typical gross when you see on pathology table or gross table. If this color is seen, we say, well, this seems to be oncocytoma. And microscopically, as I already explained, there is plethora. Plethora means a
lot.
group
Wide
combination
range.
or a wide range of mitochondria, tan color. So we see a lot of color because of excessive mitochondria, and there is finely granular eosinophilic red cytoplasm everywhere. And sometimes in the gross also you find that this white area, there is a central scar, a scar which can be running in one direction. So this is also a gross finding, and sometimes you can also find that area to be very much fibrotic. And this is not seen in this picture, but here you can find that stellate scar or a central scar.
Star-shaped.
A star-shaped scar, fibrosis in this tumor.
Are these congested vessels?
These ones? These are actually, yes, you can say they are some vessels or micro vessels which are running in between them to supply excessive, you know, if it is have to produce a lot of mitochondria, it needs energy, and it is provided by energy by ATPs. And that way the blood vessels will also be already be raised, much raised in this tumor. So they are compressed vessels, micro vessels or capillaries in this tumor. Okay? But they are not as we see in the coming tumor, which is called renal cell carcinoma. They are typically very much high. And even we call them, you have seen somebody have gone to Mazra and you have seen that they build even in shops which have chickens. So they are bound by cages which have very thin walls. Okay, so we call them, you know, the thin iron walls like that. So these are called chicken wire vessels. So the vessels which are seen in this tumor, they are proliferating as if they are like the vessel, like the chicken wire network of exactly blood vessels, like you see the cage of a chicken. So that's why it is called chicken wire blood vessels. Renal cell carcinoma is the most common malignant tumor of adults. Okay, so in adults, the most common tumor is renal cell carcinoma. 80 to 85% of all malignant tumors is in the kidney is renal cell carcinoma in adults. 2 to 3% of all cancers. If you see the whole body, then in the whole body it is 2 to 3%. Again, the main culprit is tobacco. Strongly related with that, some hereditary and familial changes, some mutations. Morphologically, again, it is very much yellowish and greenish. You can also find, you can have many, maybe the one, if in M2, yes, we will show you practical. You will find a lot of RCCs there.
Not
So,
brown.
yeah, there because of this formalin the color change, but actually it is very much yellowish green. And we see microscopically a lot of clear cells. You will see in microscopic slide also, we will give you them inshallah, the practical. So you will see there is a central nuclei or peripheral nuclei with a lot of clearing of the nuclei. So much so, there is so much clearing that we give another name to this tumor as clear cell carcinoma. That is a more common subtype of this tumor. There could be other types, for example, papillary renal cell carcinoma. This one is an example of papillary renal cells. So there is a papilla, and you see a lot of tumor cells which are arranged around these blood vessels. So this is called papillary renal cell carcinoma. This is the clear cell renal cell carcinoma, and this one is another type of renal cell carcinoma which looks like oncocytoma, but because it has some ATP of the nuclei, so we call this as chromophobe renal cell carcinoma. Okay, it is called. The third type of RCC is chromophobe. Why we call it as chromophobe? Because the granules which are seen in this nuclei, they are stained like chromo. Chromo means color, and phobe means phobia. They don't want this color. But once we stain them, they are typically having a lot of these granules. So based on this feature of this tumor, we call it as chromophobe renal cell carcinoma. So the third type is chromophobe renal cell carcinoma. Well, remember, this is one of the tumor which have early metastasis. Even it is usually diagnosed after metastasis. It is very blood loving. It goes via renal vein into heart, into brain, into lung, into anywhere else in the body. So it is having a lot of invasion to the renal vein, and sometimes it can, but rather renal vein more than the lymphatics. So it loves to go through blood vessels. And last slide for Ibrahim is that it's Wilms tumor. It is also called nephroblastoma. Remember this word.
Blastoma for children.
Blastoma for children.
Infancy.
And nephro means kidney.
Kidney.
So you can remember that this is a tumor which is common in children and in the kidneys. It's also called nephroblastoma. Wilms tumor. Why actually we call it as Wilms tumor? They found that when they go into genetic checkup of this tumor, these boys or girls who are having this tumor, they found that there was a gene at the 11 chromosomes, short arm of 11 chromosomes at locus 1, sublocus 3. At this level, they typically isolated a mutation, and based on that, they call it as WIMS, WT1 mutation, and based on this mutation, they started to change this name from nephroblastoma to Wilms tumor, because most of these tumors have this. You want to say something? Okay. So most common malignant tumor of children, less than 5 years. Remember, the most common tumor of adult males, malignant one is
Renal cell.
Renal
of
cell
kidney,
carcinoma.
renal cell. The most common tumor of children, less than 5 years is
Nephroblastoma.
nephroblastoma or Wilms tumor. Associated with many syndromes, maybe it could be associated with Dorcott syndrome, where there is tumor. It could be part of Men's syndrome, multiple endocrine neoplasias. So a lot of tumors can also be associated with this tumor. Grossly, it is usually the boy is less than 5 years. It cannot sometimes talk up to 3 years, 4 years can present. So there is abdominal enlargement, sudden abdominal enlargement. So when you see there is some mass which is going from retroperitoneum and that is pressing the anterior organs. And sometimes it is very difficult that whether it is arising from kidney by ultrasound, so they go for CT or MRI. So there is a large solitary or single mass which is very well circumscribed. You find it that it is very boundary walled. And microscopically, it contains triphasic combination. Triphasic means
3 phases.
3 types of cells, 3 types of structures. Number 1, because it is a blastoma, so obviously it should have a lot of blastomal cells. All these dark blue cells which are running here and there everywhere, these are blastomal cells. The second type of cells, they should be stromal, which should contain either fibroblast or some myxoid. So these myxoid areas, these myxoid and some fibroblastic areas, this is showing the fibroblastic or myxoid component, which is example of a stroma in this tumor. And the third type should be epithelial component in the form of abortive tubules. Abortive means those tubules which are going to end. So these are the tubules which are found in this tumor, which is a representative of the epithelial component. So what are the 3 types of cells in Wilms tumor?
Blastoma,
Blastemal, which are round blue cells. Then
stromal, epithelial.
stromal.
Epithelial.
Stromal can be having 2 components. Number 1 is
Fibroblast.
fibroblast and myxoid.
Myxoid.
And the third thing is
Epithelial.
epithelium, which is looking like tubules, abortive tubules. So the problem is in which genes?
11.
Q,
Q13.
WT1 gene, which is located at
11Q13.
11P.
P.
P13. It's not 13, it is 13. Huh? In genetics, they will tell you that we call this as
locus 3.
yes, locus 1, sublocus 3. So, what are the 3 types of renal cell carcinoma?
Papillary.
Papillary. Most common is clear cell, up to 50-60% clear cell. Chromophobe and
clear
papillary
cell.
and clear cells. Okay. So, what about oncocytoma? Anything about oncocytoma? What is the gross color?
Mitochondria.
Mahogany brown. And on microscopy,
A lot of
a
mitochondria.
lot of mitochondria, which will give a lot of granular cytoplasm, eosinophilic cytoplasm. Okay. Anything about rapidly progressive?
I don't know.
Most common is
Yes. Anything about rapidly progressive? There is rapid deterioration of renal function and oliguria. What are the 3 types?
Immune antigen antibody
Immune complexes,
complex,
exactly.
or immune suppressor or operative immune.
Okay.
Cell membrane.
And damage to the cell membrane. And what is microscopy of this? What is the other name of rapidly progressive?
Crescentric.
Crescenteric. So hilal light.
Yes.
So why we microscopy we see halals. And what are the 3 types?
Crescent.
Antibody complex.
Type 1
Antigen,
is
antibody
antibody against glomerular basement membrane.
Yeah.
Now type 2 is
The protective immune.
because of immune complexes.
Yes.
And type 3 is
Increase
No
immunity.
immune.
no immune, passive immune.
Positive.
Okay. Where is Ahmad Muhammad and Ahmad